Hello, thank you very much for your fabulous efforts today. We've collated a series of questions. Some of them are clearly meant for a specific person, but we're really making it open for all of you to answer. So if anybody wants to contribute to any of the questions, they're very welcome. Okay. So our first question is probably directed at you, Irene, and it says, do you have any references for swallowing difficulties with altered lingual frenulum?
Sorry, can you repeat? I am not totally attentive.
Do you have any references for swallowing difficulties with altered lingual frenulum?
If I have a reference?
Reference.
Yes,
reference.
Biography, bibliography.
Yes.
Yes, there is. I don't know if the person is asking if I write something or if I had from other authors, okay? Yes, we have from other authors, and we write about that, what happens when the person have frenulum, and what is the adaptations that the tongue needs to do for better deglutition. Yes.
Okay.
There are in the literature, and we wrote about that too.
Okay.
Okay?
Lovely.
Then, as I told before, I can send the bibliography about what I did, I talked, and for ASTLiT, for the society, then they can distribute that. Okay?
Oh, lovely, thank you. Would anybody else like to make a comment about that? Any other references that they might know of or be working towards in terms of swallowing difficulties?
So tomorrow I'll present our study design, and we don't have all of the results from that, but we've measured the suck, swallow, breathe measurements that you saw today on the tongue-tied babies, and that was the initial thrust of the study, is to look at if that coordination was affected during breastfeeding and swallowing, but we don't have that data crunched yet, so it's coming maybe next year.
Okay, that's right, next year, next conference.
You produce a lot.
In relation, yeah, okay.
It's true.
Also, Irene, following on from you, another question. Someone's asking, what is the difference between systematic and unsystematic distortions?
For us?
For you?
For me, systematic and...
Systematic and unsystematic distortions.
I don't talk about that, but I imagine systematic disorders, I imagine, is something that is always in any situation occur. And asystematic, for example, I am drink something and this is asystematic. Something that happens sometime. I don't know if the question is this. No. Systematic, what repeat all the time is the same way. All the deglutition is the same way. And the asystematic is different because can occur or not for any reason.
Okay, great, thank you. Donna, this one is for you. Do you think that by mums taking home scales and doing a lot of weighing of babies pre and post feed, that this could affect breastfeeding rates in some way, given the WHO recommendations for weighing in the first year?
Do you mean negatively or positively?
Anything you like.
So we have quite a few publications now because we've been doing this for the founder of the group for about 30 years, and we have an online website, we have apps for iPhones and Androids, And because the new generation like to use those, they put in the weights. Or if you're old style like me, you write them all down and make somebody else type them in, like your husband. And we were criticised that it would undermine women's confidence, but that was back in the days when it was one test weigh, and child health nurses were weighing the baby before and after one feed, and we know the variability over 24 hours is quite marked. And so what's important is what the baby gets over a day. Now, when we studied the confidence of the mothers before and after doing these procedures, they were fine. They like it. If they have any insecurities about their breastfeeding, seeing that their baby gets enough milk is incredibly positive. Now, we did have some mothers, a small group, whose confidence decreased, and that was great because they had really low productions. So what we've been doing and what we're working on is using the scales in times when there's problems. So in the breastfeeding centre, we gave them 8 scales, which they think they own now. It looks like I've lost them. And they use it during practice, and one of the things they use it for is to convince a mother that she hasn't got enough milk and that she has to express or she has to top up, because we're looking at much higher rates of intrinsic low milk production now. We're starting to see zinc transporter mutations, obesity, which means the gland doesn't develop properly, and women may not get a good milk production. So we're also using them to encourage mums to top up appropriately and keep breastfeeding. So we're kind of sliding into that realm of trying to use them, not with every mother. Certainly you don't want to do that. And it's been successfully used in the NICUs in the US. So there were 2 professors that use it at Sick Kids at CHOP in Philadelphia and at Rush, Chicago. So, and you know, you don't have to strip the baby. You weigh the baby before and after the feed, whatever they've got on. So, I think that answers. I think the presentation tomorrow will show you why that might increase rates in women that are having problems.
Right. Okay, thank you.
Just for the,
A question for Soroush. Tonsillectomy versus tonsillotomy for paediatric nighttime enuresis with pre- and post-orofacial myology. That was not a question, it was a statement. I'm just reading it out as it was written. So I'm not entirely sure what they were asking, but those were the topics that they wanted to touch upon. Have you any results or have you looked at that?
Tonsillectomy versus tonsillotomy, maybe different ways of addressing and doing the procedures. Just like with the frenum, you can do frenectomy, frenotomy, but I'm not really sure what that question is kind of.
Yeah. I guess maybe they're asking, has there been any correlation with paediatric nighttime enuresis, as well as pre- and post-orofacial myology as well?
So perhaps they're referring to an article that I'm not familiar with, but in our practice, we do see that when you remove the tonsils and you get them into myofunctional therapy, you oftentimes do see resolution of bedwetting, but sometimes you still don't, because you have to retrain them out of that behavior as well. The most interesting that we see is changes in growth, because you get growth hormone released during deep sleep. You see changes in behavior and mood and the quality of sleep that the child is experiencing. Yeah.
Thank you. Do you want me to? Yeah. Okay. Yep. Thank you.
This one is a question from me, and this is for Maxwell, and it's to ask, what do you see as your role as an osteopath in supporting mothers and babies post-tongue-tie division?
Well, obviously, even if a tongue tie is slipped at an early stage, there's still a pattern that has been established. Babies are using their tongue from very early on, as we saw some of those early photographs. So the way that they are using the muscles that are supplying the platform to the tongue, the way that the tongue is moving, the way that the hyoid is moving, and the way that their head posture is in relation to the neck, all of those things will be involved if they've been compromised, even though they've had a release. And it was really wonderful to see how somebody at 60 could literally recreate themselves by going through a procedure, and it's a real testimony to the amazing ability of the body to grasp something and run with it when it gets the opportunity. And that's what I find with kids. But I do think the contribution that we can make still is to support that ongoing process so that the flower fully comes open. Yeah.
Yes, thank you. Does anyone else in the panel have a comment in relation to that? No? Okay.
Okay, another question for Irini. A lot of your subjects had anterior tongue ties. Do you see posterior tongue ties, and what problems do you see associated with those?
Okay. I have. I think I don't understand the end of the question. Please, again.
Do you see a lot of posterior tongue ties or submucosal?
If I see,
Do you see them, and what sort of problems do you see associated with those?
associate with other things,
With the posterior or submucosal tongue tie?
So a lot of the tongue ties that you describe in your scale is the mucosa, the frenum actually, but sometimes behind the frenum there can be muscular attachments that still hold the tongue down, or fascia elements, and they describe that as posterior or submucosal, and they want to see your perspective on that.
okay, now it's clear.
Sorry. Thank you.
The question. Or I understand better because it's near me. The problem is maybe the language. Of course, I am not a surgeon. I do not surgeon. This is a decision of the dentist or ENT that will do the surgery. But I saw many surgeries. Then when it's in baby, in general, they only liberate exactly the frenulum, and if there are some fibers lateral, include with the finger, they liberate this kind of fibers. And another surgery, when the frenulum is more tight, a lot of, many times a lot of blood, and it's a surgery a little more complicated. In Brazil, the surgeries are done, the major part, the people, with scissors, not laser, because laser is something very expensive for our country, and there are some places that use laser, but the majority of the surgery uses scissors. Then they cut the principal part, then with many times with the finger, they see if some lateral fiber is tightening the movement of the tongue, and they do that. But this is a decision of the surgeon, not our decision. And the importance for us is after the surgery, I don't do that, and someone asked me during the coffee, and I put here, when the surgery is done, we follow up the patient during a month, seeing the patient once a week to see if it's okay, if they need some revision for the doctor, with the doctor, and if the speech, when have problem of speech, because it's not obligatory that there are speech problems. And we, after 1 month, we decide if the patients need or not surgery. We work with different kind of people: rich people, medium people, and poor people. We work in places that the people can't afford, can't pay anything. But we do this kind of service 1 or twice a week to attend, to see this kind of people. And they can't afford, they can't pay for any treatment. And as we follow up after surgery, in any class of people, rich or poor, what we see, some patients need therapy. Some patients doesn't need therapy. They can speak, they can, after 1 month, 1 month, 1 month and a half, they can move the tongue perfectly and speak better and speak in the correct way, and it's not necessary therapy. Only we put in therapy or recommended therapy when they can't speak well or when they want something that they can't do. In general, when liberate the frenulum, when the surgery is good, the tongue goes up. And of course, we talk with him and with the mother that this is very important after surgery, after the basic cicatrization, to move the tongue. And the elevation is not necessary to do for all patients therapy for elevation the tongue. The majority of them can elevate the tongue. It's not necessary to train the patient. It's more important not the movements that they will acquire during mastigation, during speech. It's more important to see if they can speak well or not, all the sounds. And if they need therapy, after 1 month, we put in therapy. If they don't need, we don't put in therapy. It's not necessary to start a therapy.
Wonderful, thank you. We do have more questions, but we're a bit out of time, so we might carry some of those over for tomorrow's session as well. Thank you.
Okay.
Thank you. Thank you.
Thank you very much for attending today. I'd just like you to thank our speakers again for a great day of sessions.